Good evening, all. Welcome to the webinar of SFM. This time, um, as we celebrate the National Youth Day, all the speakers that you will have see today or hear today are one of the most phenomenal speakers you'll ever hear. If any of you have ever attended NeuroCon, the highlight of that conference were presentations from the remotest corners of the country, all by young people. And this showed by the images, by the follow up, by the quality of presentation that wherever you are, in whichever corner of the country you are, if you have the dedication, if you have that passion, you can, make your work present. And they just did a wonderful job in Eurocon. Uh, we all got to see so many new talents coming up. So as we celebrate the National Youth Day today, I specifically I feel so proud to have the youngsters from MP who have already proven themselves. They have the best of machines, they create the best of images, and they keep posting them in the WhatsApp groups. They keep enlightening other people. And this is what the SFM is all about. We want your work to be presented to the world. We want you to do good work. We want you to take good images and present your work to the world. All the speakers that you will hear today come from Madhya Pradesh. They are young and they have phenomenal work in their kitty. Even in spite of being at such a young age, they have seen enough and they have known how to create those images, how to come to a diagnosis, how to prognosticate, how to counsel, and they have followed it up so that you will have a comprehensive picture of whatever they show. So I would personally congratulate each one of you to have present your cases on this August platform and showcase your cases to the world. I wish you all the best. And to take it forward from here, I invite Dr. Alok Vashni, who himself is a brilliant sonologist with special interest in the heart. He will conduct this session and take it forward. All the best to you, my dear friends.
Thank you, Mohit sir, for this warm words of introduction. Good evening, everyone, and thank you, all of you who have joined here today. Today is a special day, and we are going to see some cases being presented by our young presenters. And these are cardiac conditions which are, they can be very challenging to diagnose, but these have significant implications. Many a times these are misdiagnosed in certain other conditions. Our panel of speakers is young, but they already have wealth of knowledge and experience. And without further ado, let's dive into today's discussion. We are going to keep the question answer session at the end of the talks, at the end of the presentation. So please send your queries, questions into the chat box, and we're going to discuss all of these at the end. So let's start with the first speaker. The first speaker is, let me just share the CV slides for these. Yeah. So the first speaker is Dr. Gurdeep Chabra. He is a MD in radio diagnosis. He also has a diploma in musculoskeletal ultrasound. He is currently the secretary of Fetal Medicine, Society of Fetal Medicine in Madhya Pradesh Chapter. And he holds many posts. He's a very dynamic person, very wonderful radiologist, quite resourceful, diligent. Let's see his work and we'll see how good he is at what he is doing. So over to you, Gurdeep. You can share your case, please.
Yes, sir. Thank you, Alok, sir, for the kind words. First of all, I would like to thank Dr. Ashok Khurana, sir, Dr. Mohit Shah, sir, and Dr. Reema Bhatt, ma'am, for providing us this opportunity and this platform. So, good evening, everyone. My first case is about a primary 26-year-old who was referred from a periphery she was 20 weeks in gestation, and someone had diagnosed that the three vessel view was abnormal. So this patient was sent to me for further investigation. So as we start fetal echocardiography from the fetal abdomen, the fetal abdomen revealed normal situs. The abdominal aorta was on the left side, the IVC was on the right side, and the stomach was normal in situs. Then we moved on to the 4-vessel view, in which we saw the normal position, axis, the normal arrangement of the chambers. The aorta was also normal, retrocardiac area was also normal, and the cardiac size, compression, squeeze, everything was normal on this. So we moved on to the outflow tract view. And in this, we saw both the outflow tracts were normal, and there was no any VST or any transposition of great vessels. Then we moved on to the 3-vessel trachea view, in which we saw that the aorta is on the right side and the ductus arteriosus is coming on the left side. And there was a vessel, the normal V sign, which is seen on the 3-vessel trachea view, which is formed by the confluence of the aortic arch and the ductal arch. And this normal V sign should be seen on the left side of trachea, but this V sign was completely absent, and there was a U sign visualized. If you can just imagine that this is a U, and there was a loose vascular ring in the retrotracheal and retroesophageal area. There were no other cardiac or any extra cardiac anomalies seen, and no other signs of aneuploidy were present in this fetus. The power Doppler view also showed the same findings. Then basically on 3-vessel trachea view, we saw the normal arrangement of the ductus, aorta, and SVC from left to right, but the V sign was not formed. Also, the pulmonary artery was bifurcating normally, and there was no bifurcation of the aorta. The thymus was also normal in this case. Also, we confirmed that it was not the aorta which was bifurcating, but it was the normal ductus which is bifurcating. The importance of this we'll see in the differentials as we discuss it. So again, we saw the same findings, that is the ductus and aortic arch. They were joining behind the trachea, forming a U sign. The SVC was also normal in caliber. Both these vessels show normal flow direction and flow velocities. On the sagittal view, we again confirmed the ring, and there was an aberrant vessel which was arising from this ring. So my diagnosis in this patient was right-sided aortic arch with left-sided aberrant subclavian artery with Comerill's diverticulum. So we took the power Doppler images of the same patient, and it revealed this retroesophageal segment, which is called as the Comerill's diverticulum. And from this vessel, we could see the aberrant left subclavian artery originating. Also, the aorta showed the first branch from the aorta was the left common carotid artery. As you can see in this schematic diagram, the aorta gives first branch as the left common carotid artery in this case. Then there is right common carotid artery, and then subclavian artery. And this aberrant left subclavian artery is being supplied by the diverticulum of Comerill. And this diverticulum of Comerill is connected anteriorly via the ductus venosus and posteriorly to the descending aorta via the diverticulum of Comerill, and this supplies the aberrant left subclavian artery. In neonatal life also, after the closure of the ductus, this aberrant left subclavian artery is supplied by the diverticulum of Comerill. It persists even in the postnatal life, and it is supplied by the descending aorta. So as we saw that the first branch was left common carotid artery, we could trace the other branches also, that is the right common carotid artery and the right subclavian artery as shown in this schematic diagram. So this further confirmed our diagnosis. And this was ULSA, which was obtained by the power Doppler. This is again the schematic diagram of the diverticulum of Commerell and the blood circulation schematics drawing. Then 3D stick were used to obtain the relationship of the vessels and to further confirm our diagnosis. So these 3D images also again showed the ring, the vascular ring, which was loose. This was a 3D stick rendered image. So coming to the this anomaly, basically the normal 3-vessel trachea view should show the confluence of the ductus and the aortic arch towards the left of the trachea. This should always be kept in mind whenever we are obtaining the 3-vessel trachea view. And in this case, there was an abnormal vessel which was passing in the retrotracheal region and retroesophageal region, and this was forming a loose ring. So what are the other aortic arch anomalies which are commonly encountered? It's the right aortic arch. The number 2 is double aortic arch, and number 3 is aberrant subclavian artery. This is the most common. The right-sided aberrant subclavian artery is the most common. So there can be a simple right-sided aortic arch with right-sided ductus arteriosus, and in this case, the confluence will be on the right side of the trachea. And there would be no ELSA or any ARSA, and there would be no any ring around the trachea in these cases. Now, the second differential in this case, which was very close, is a double aortic arch. So how do we rule it out is in this case, in case of double aortic arch, we can see that the right and left aortic arches are the aorta is bifurcating into the right and left aortic arches, and then these two arches form a complete tight ring around the trachea and esophagus, and this is quite symptomatic and needs surgical intervention. Right-sided aortic arch. What we should see in this such cases is that trachea is the landmark, and we should always trace this V and see it is definitely on the left side of the trachea. So in this case, the right-sided aortic arch is seen with right-sided ductus. And in our case, this was the abnormality in which we could see the retrotracheal vessel, that is the Commerell's diverticulum. And the double aortic arch in which the aorta bifurcates into the right and left arches and forms a complete ring. So these 3 differentials should be kept in mind while looking at the 3-vessel trachea view. So our diagnosis was left-sided aortic arch with retroesophageal diverticulum of Commerell and aberrant subclavian artery. Diverticulum of Commerell is a protrusion from the proximal descending aorta. It is directed posterior to the esophagus and to the right. And etiology, embryology is same as the right aberrant subclavian artery. These cases are mostly asymptomatic in postnatal life because the ring is relatively loose. Sometimes there can be dysphagia due to compression of the esophagus, and in few cases subclavian steal syndrome may occur. And very, very rarely there can be a risk of aneurysm for which surgical correction may be recommended. So just embryology in short, there in this case, there is regression of the right-sided 4th arch and persistence of the right-sided 6th arch, which leads to this retrotracheal segment. During the normal embryogenesis, there are actually two aortic arches, the right side and the left side. Normally, what happens is the right side aortic arch regresses and the left side persists. But in these cases, what happens is the right-sided aortic arch is persisting and the left-sided regresses till the origin of the subclavian artery. So this is the normal aortic arch. schematic diagram. And the various types of right aortic arches can be right aortic arch with mirror image branching, right aortic arch with ALSA like we saw in our case, and right aortic arch with isolation of the LSA, that is the left subclavian artery. So these cases are commonly associated, talking about the genetics, commonly associated with microdeletion 22 and trisomies, but most commonly trisomy 21. But in this case, we could see that the thymus was normal. The patient was advised to continue the pregnancy, but and they were even advised to have this invasive testing with chromosomal microarray, but they did not listen, and being from the rural area, they got scared and they terminated this pregnancy. So that's how it went. And so that's it. That's the end of my case.
Thank you, Dr. Gurdeep, for excellent presentation. Wonderfully imaged case. Unfortunately, the outcome, was not good. But in our experience, the outcome for right aortic arch with left ductus, it's quite good.
Yes.
And these babies, they do well because not
Yeah.
much is, occasionally they may require some kind of a surgery, but more often than not, everything goes quite well. The foremost differential diagnosis is uh, double aortic arch, because that is the commonest challenge
Yes.
that we encounter, because the left carotid artery, it arises from the right sided aortic arch and then it travels towards the left side of the
Yes.
neck, and then that is overlapping the ductal arch. So,
Yes.
but yeah, so ALSA in particular, if you see aberrant left subclavian artery,
Yes.
so that is a very good way of noting that this is a right aortic arch with left ductus.
Yes.
Because in a double aortic arch, embryologically we know that both the arches, they should give out two branches each.
Yes.
Whereas the branching pattern in a right aortic arch with left ductus, it is little different. But very nicely imaged, wonderful case. Thank you. Good start to the webinar. Thank you.
Thank you.
So next, I would like to invite Dr. Pramod Bapna. Let me share his CV. So let me just stop the share once more. So Dr. Pramod is a consultant sonologist at Advanced Bapna Mediscan, Devas MP. It's a small town near Ujjain, and he is a wonderful, diligent person. I got to know him last year when I visited Indore, and he he's very, very active in Society of Fetal Medicine in Madhya Pradesh and in IRI forums as well. So over to you, Dr. Bapna. Please present your case.
Dr. Bapna, we can't hear you. You have to unmute yourself.
Yes.
Am I audible now, sir?
Yes, sir.
Hello. The history is Mrs. A. She is age 24 years. She's gravida 2 with one abortion at 10 weeks. And this pregnancy is now, when I imaged, was around 21 weeks and another termination of pregnancy for this pregnancy also. There is no significant medical history and no first trimester screening or routine scan was done for this case. As we see on the four-chamber view, what we see, it appears to be a relatively normal appearing four-chamber view with a mild degree of left axis deviation. But I've kept this picture on purpose over here because most of the times what we in a hurry only see the four-chamber view and we do not image the outflow tracts. As we see in this outflow tract view, there is a large overriding vessel with the malaligned VSD. This is the image showing a normal situs, the stomach and the left ventricle and the left atrial area. Only subtle finding on the four-chamber view was a bit of left axis deviation, which was around 71 degrees. The outflow view showed a common vessel arising, a malaligned VSD and a single overriding vessel. Then as we move on to the three-vessel trachea view, what we see is a left-sided superior vena cava, a right-sided superior vena cava, a prominent vessel, and no pulmonary artery as such, and a relatively small appearing thymus. So the findings so far, what we have is a normal four-chamber view with a bit of left axis deviation. There is a large perimembranous VSD. There is an overriding large vessel, two vessels, and a left-sided SVC and a relatively small thymus. The thymic ratio, which we calculated in this case, was 0.28. And as per literature, it should be more than 0.33. So the thymus is relatively small in our case. Then we did a color Doppler evaluation of the same. It shows a large overriding vessel. We were a bit confused earlier whether this is a pulmonary artery arising from this vessel, but on grayscale, we could not confirm the origin of the pulmonary artery. So also we could see from the branching pattern that these are the neck vessels and there is an abnormal vessel arising from this point of, this is the ARSA. Further imaging, we could pick up MAPCAs over here. These are arising from this large vessel and going into the lungs, and a MAPCA over here also. So the summation of the findings so far, we have got a left axis deviation. We have got a perimembranous VSD with a single large outflow. Pulmonary artery could not be demonstrated. There are MAPCAs. There is a left SVC and a ARSA and a small thymus. So whenever we see a case of VSD, we should first see what is the overriding vessel, whether it is a non-branching vessel or it is a branching vessel. Branching into two, that is the pulmonary. What is the degree of our override? Is it from the greater than left 50% from the left ventricle or less than 50? What is the origin of the vessel? Is it from the ventricle or is it from the great vessel? And what is the caliber and flow through this vessel? So as we know, we had a VSD with the overriding great vessel. Then we evaluated for the pulmonary artery. In our case, we could not visualize the pulmonary artery very well. And we could also demonstrate MAPCAs in our case. So we reached to a conclusion of pulmonary artery atresia with VSD in our case. Pulmonary atresia with VSD, malaligned VSD, overriding vessel, aorta, degree of override that is greater than committed, 50% committed to the LV, PA originating, we do not know whether it is originating from the, and we could not. The caliber of the pulmonary artery was not reliable. We could see MAPCAs. So grading of the pulmonary atresia with VSD has been type A, where we have a pulmonary artery, but there is a retrograde filling of this pulmonary artery from the large trunk. You may have a short ductus with MAPCAs, or you may have only the MAPCAs. So our differential also includes a common arterial trunk. But in a common arterial trunk, we definitely see a pulmonary artery arising from the common arterial trunk. Whereas in a pulmonary atresia, the artery is very, very small or not visualized. Then the flow in a common arterial trunk, the flow in the pulmonary artery would be in a forward direction, but in a pulmonary atresia, it would be a retrograde filling. Then the overriding vessel is more from the right ventricle in the common arterial trunk, and the overriding vessel is from the left ventricle in the pulmonary atresia. And the most important point is the presence of MAPCAS goes more with a pulmonary atresia with VSD. Another differential is from a very top, where we can say very stenosed pulmonary artery. Earlier, it was called as TOF type 4, but the visualization of the pulmonary artery is there in TOF, and this TOF type 4 is now classified as pulmonary atresia with VSD. We did a genetic evaluation of this abortus, and it turned out to be 22q11 microdeletion. Thank you very much.
Thank you, Dr. Pramod, for excellent presentation. Very nicely imaged case. And two very important points you have brought out. One, that the left axis deviation is very important to pick in a four-chamber view, because this is a marker for conotruncal abnormalities like common arterial trunk, PAVSD, TOF, etc. So this is quite important to pick up. And the second thing is that you brought out the differential diagnosis between common arterial trunk and the pulmonary atresia with VSD. This is again a problem because we see just a single vessel arising from the overriding the VSD, and then sometimes we do not know whether it's a common arterial trunk or a PAVSD, especially in the early gestational ages. So I think you've summarized your case well. Thank you so much.
Thank you, sir.
Okay, next we have Dr. Mansi Jain. She is a consultant from Bhopal, consultant radiologist from Bhopal, and she is brilliant and quirky, and you can guess from her psychedelic background how quirky she can be, but she's a wonderful orator, very, very nice images she creates. So over to you, Dr. Mansi.
Hello, everyone. Hi, I'm Dr. Mansi from Bhopal, and thank you, Society of Fetal Medicine, for this opportunity. So I'll be talking on Tetralogy of Fallot. First, just a diagram. In Tetralogy of Fallot, we have a ventricular septal defect, and the aorta shifts rightwards, and it falls over the septum, that is overriding the septum. And because it shifts rightwards, it compresses the pulmonary artery, and there is pulmonary artery stenosis. Later, there is right ventricular hypertrophy. So out of these four things, what we can see prenatally are the stenosis in the outflow tract of the right ventricle, ventricular septal defect, and aortic override. Now coming to the diagnosis by ultrasound. So in a four-chamber view, it may be normal, or it can have a left axis deviation. So it can be normal, or it can have a left axis deviation. Five-chamber view, star of the show. What we'll have here, we can see the malalignment of the ventricular septal defect, and there is aortic override. That is, aorta is sitting over the septum, and both are parallel to each other. Here we can see the Y sign of the aortic override. So these are the zoomed images of the same. So here we can see the aortic override Y sign. And here, because this aorta is getting blood supply from both the ventricles, it becomes large, it becomes big, it becomes like a question mark. So this large aorta is an important diagnostic clue for diagnosing tetralogy of Fallot. Now coming to the diagram, which makes things easier to understand. So here we have to see the septo-aortic continuity. If there is breach in the continuity without any malalignment, it's a perimembranous VSD. And if it is overriding the malalignment, that is aorta is overriding the septum and receiving blood supply from both the ventricles, then it is the malaligned VSD with overriding of the aorta. Now, when there is override, we have to see how much is the override. If it is more than 50% of the override and both the vessels appear to arise from the right ventricle, then it is double outlet right ventricle. And if one of these, if the pulmonary artery is smaller in this case, then it is DORV TOF type. And if there is altered arrangement of these two vessels, then it is DORV TGA type. And if we can see only a common trunk and pulmonary arteries arising from it, then it is a common arterial trunk. So these are the ultrasound images for the same. We just have to see the septaortic continuity. If there is breach in the continuity without any malalignment, this is perimembranous VSD. And this big image showing the large perimembranous VSD with malalignment, that is aorta is overriding the septum. And when the override is more than 50%, then it is double outlet right ventricle. Now, when we are done with these two things, we have to classify the abnormality. So what we do is we look at the pulmonary arteries. We look how small they are or whether they are or not present, whether they are present or not. So when they are of normal size, then it's simple mal-aligned VSD. If the pulmonary artery is small in caliber, then it is TOF with pulmonic stenosis. If there is non-visualization of the pulmonary artery and large dilated aorta, then it is pulmonary atresia, TOF. And if the pulmonary artery and its branches appear massively dilated, then it is absent pulmonary valve syndrome. So this is a case of pulmonic stenosis. Here, the ductus attaches to the side of the distal arch in a branch-like pattern. Normally, what we see in normal babies is they attach in a V-shaped pattern. But in case of pulmonic stenosis TOF type, they appear like a branch. And this is pink TOF, where we have antegrade flow in this pulmonary artery. When we have retrograde flow in the pulmonary artery, it means it's so severe that it is getting blood supply from the ductus retrogradely. So these babies are blue TOF. And when they are born, they are duct dependent. Now, whenever we are not able to find pulmonary artery at all, that is pulmonary atresia case, then we look from where this lung gets its blood supply. So we search for any vessels arising from the systemic circulation, that is the aorta, and we can trace these MAPCAS. So MAPCAS make things easy. That is, severe forms of TOF have MAPCAS. And the important is risk of 22q11 microdeletion increases up to 50% if MAPCAS are present. Now we come to the measurements. We measure everything possible, but Z scores are, we take the Z scores. Then we take ratio, that is mean pulmonary artery upon the aorta ratio. Why are we taking the ratios? Because we want to assess progression. So in severe TOF, how severe means? Whenever the pulmonary artery is almost half the size of the aorta, then it is severe TOF. So whenever we find a malaligned VSD with overriding of aorta, we take the measurements and then we take the ratios. And then we decide whether it is mild form or severe form. And how to predict duct dependence? We take the ratios. If the ratio is like pulmonary artery is half the size of the aorta, Z scores are less than -3, retrograde flow in the ductus, and high peak systolic pulmonary valve gradients, then it falls into the category of duct dependence. Now we look at the associated anomalies, any cardiac or extracardiac. So whenever there is abnormality in the aortic arch-sidedness, like right-sided aortic arch, or there is thymic hypoplasia, then we suspect 22q11 microdeletion syndromes. So genetics is also a part of congenital heart disease, because in up to 30% of the CHDs, there are associated genetic disorders. We have to send the sample for array and also VES in selected cases. This is one of the report of one of our patients who was having Tetralogy of Fallot, and there was some gene identified which was responsible for it. Now coming to the prognosis and treatment, because that matters to the patient. So absent pulmonary valve syndrome, very, very bad prognosis. Pulmonary atresia, bad prognosis. And pulmonic stenosis is kind of a good prognosis. So whenever we have bad prognostic cases, that is duct-dependent babies, they have shunts as soon as they are born. So they can have shunt from subclavian artery to the pulmonary artery, or they can have stent within the pulmonary artery. And finally, they can have the definitive surgeries, like patch the VSD, correct the infundibulum protruding into the pulmonary artery, patch it up. Now coming to the presentation, first is a patient was referred to us for tricuspid regurgitation in level 1 scan. When we did the scan transabdominally, we couldn't see any obvious abnormality in the heart. We could find as a single umbilical artery. Then we used a Brahmastra, that is a transvaginal scan. When we did the scan, what we could see was a VSD coming. So we can see an overriding aorta with a perimembranous VSD, large dilated aorta, and a small pulmonary artery. And the pulmonary artery had a antegrade flow. So it was TOF with pulmonic stenosis. So these are the still images, overriding of the aorta, malaligned VSD, pulmonic stenosis, antegrade flow. Finish. Diagnosis, TOF with pulmonic stenosis. Teaching points is fetal indications for early fetal echo is increased NT, abnormal DVTR, single umbilical artery. So whenever you find this, please use a transvaginal scan and do a good early fetal echo. Now coming to second case. Sorry for the image, it's from old machine. So what we can see is large VSD, overriding of the aorta with large dilated aorta and non-visualization of the pulmonary artery. So this was a case of TOF with pulmonary atresia. This is another case. There was overriding of the aorta with the malaligned VSD, and on color images we can see the same, that is overriding of aorta, malaligned VSD, and possible retrograde flow in the pulmonary artery, and hence a diagnosis of TOF with pulmonary atresia. This is another case where we couldn't find the VSD, but we can see is tricuspid regurgitation, and there was retrograde flow in the pulmonary artery. So it was labeled as pulmonary artery, pulmonary atresia with intact interventricular septum, type 2. And this was another case where we could just find a univentricular morphology. Dilated aorta, pulmonary artery was not visualized, and we could trace some vessels coming from the aorta and supplying the lung, which were map cards. Now coming to our last case, this star of the show. So here we could see was a left axis deviation, abnormally enlarged heart, dilated right chambers, VSD, overriding of the aorta, abnormally dilated pulmonary artery and its branches, tricuspid regurgitation, the pulmonary valve also was showing regurgitation, that is to and fro flow, resulting into abnormally enlarged pulmonary artery and its branches. So these are the still images. Once we see it, we will never forget. So this is bowtine or whale tail sign, and this was a case of absent pulmonary valve syndrome. So this was a TOF type absent pulmonary valve syndrome, which is very common, commoner than the non-TOF type of absent pulmonary valve syndrome, where we will not be able to find a VSD. Thank you.
Thank you, Dr. Mansi. Wonderful collection of cases. You've shown the entire spectrum of Tetralogy of Fallot quite well. And once again, you've shown you're master of imaging. Thank you so much. Wonderful cases. Good presentation. Next we have Dr. Kulbhushan Vishnoi. Let me show his CV. Can we see, are we able to see his CV?
Yes, sir.
Okay. So Kulbhushan is a young radiologist. He's from a small town of Harda, but I find he has exceptional eye for detail. He does a wonderful imaging, and he is very, very passionate about getting, good cases, good images. So if I want something, some rare case, he's the person I go to. So over to you, Kulbhushan.
Thank you, sir. Thank you so much. Good evening, everyone. At the outset, I would like to thank our President, Dr. Harish sir from MP, and Dr. Alok sir, Dr. Vimal Sahni sir, Dr. Mohit Shah sir for giving us an opportunity to present. And special thanks to Dr. Ashok sir, Ashok Khurana sir for giving us this platform and youngsters from small town to present here. Thank you so much, sir. I'm Dr. Kulbhushan Vishnoi from Harda, MP, and today I'll be presenting a case. A 20-year-old Gravida 2 came for an anomaly scan, NT scan done elsewhere. So while doing an anomaly scan cardiac evaluation, the first thing we look at the fourth chamber, wherein you can see here the intact interventricular septum. and the chambers look normal. I hope you all agree to that. Next, we would like to see is the LVOT, left ventricular outflow tract. And you can see that the septo-aortic continuation is maintained and intact, and there is no overriding of the aorta. I hope you all agree to that also. Next, I would like to see the RVOT. I can see the branching as well. So we are fine with the chambers and the outflow tract. So next, what would we like to see? Three vessel view and the three vessel trachea view. So in 4-chamber, everything is normal. The outflow tracts are normal. So we are doing good till here. Okay, so let's try to decode it together. Look at this cine loop, wherein you can see the stomach, the situs well on the same side. Everything looks normal. The 4-chamber, we're doing good. And what do we see when we come to the outflow tracts or the three vessel trachea view? I can see there's definitely something wrong. And also we can see an extra vessel there, which I'll show you. Yes, that extra vessel is the PLSVC. I hope you all agree to that. But what is missing, as told by the lecturers in previous cases, that proper three vessel view, the V which should have been formed here, is not there. It's missing. Something wrong with that V. So what do you want? You will come to a diagnosis with this, or you want more color clips? So let me show you some color clips here. A good inflows. What do I see in the three vessel trachea view? The V is missing and there's a lot of turbulence there. So at the first instinct which I got this in the three vessel trachea view, I was thinking of an interrupted aortic arch. So to clear my doubt, I wanted to see the full arch. So in this lateral view, again I could see the arch looks good to me. I can see some of branches, they are also fine, but still there is some turbulence there. Agree? So now, thinking about all this, with the turbulence in the three vessel trachea view, and if you see this still image, what is it showing to us? That there is a communication between the aorta and the pulmonary artery. And the V which I was expecting is discontinued and looks like a Y. Agree? Because the aorta and the pulmonary artery, instead of joining at the level of ductus, are joining at a window before the ductus arises, and there is turbulence too. So why is it all this happening? The V is missing and we are getting a Y appearance. So you have to recall a bit of embryology here, like of heart. When there is a development of interventricular septum, and when one ventricle becomes two, the same way there is a division of the main truncus, which divides into two vessels with a conotruncal ridges by spiral remodeling. And that is not happening here. So this gap between is of approximately more than 8 mm. So the first differential with the literature available was the AP window, aortic pulmonary window. And we have some good signs for the early diagnosis also, wherein you can see that you can see a red dot sign, and it is a vascular fistula that is appeared as a reversed or a turbulent flow in the middle of the right ventricular outflow tract, which is also, they have termed it as a red eye sign in this paper. But still, I think there's a lot of validation required for this. So when we finally came to the diagnosis of AP window with the available literature, and we thought that, okay, this we have to look at other things, but there was no other abnormality. What other abnormality we saw was the PLSVC, which is normal variant. We also thought of differentials and thought of measuring the thymus, which was within the normal centiles. So we counseled the patient that what all the postnatal follow-ups we need. and we need to investigate to rule out any associated abnormalities of chromosome or any association with 22q microdeletion. So we investigated this patient and the microarray turned out to be normal. So next we counseled the patient, but the patient was lost to follow-up and terminated also and did not revert back. So I would like to show you the postnatal types of AP window. The first type is the proximal defect, wherein you can see it is proximal, and type 2 is distal defect. And type 3, there is a total defect, wherein there is a long segmental defect, and intermediate is between both of the two. So there is this case series wherein they have diagnosed 4 cases. You can have a look and know about the types and their postnatal follow-up also. So some inputs about AP window. The incidence is 0.1 to 0.2% of all the cardiac defects in live birth. It is the defective development of the conotruncal ridges. Always look for separated seminar valves and a defect just above the valves between the ascending aorta and the main pulmonary artery. The communication defect should be minimum 8 mm to rule out other differentials. 3-vessel view and 3-vessel trachea view is a diagnostic view. It can be identified as early as in first trimester. The hint would be reverse flow in the middle of the main pulmonary artery, the red eye sign, and it still need validations. Associated with arch abnormalities, interrupted aortic arch and coarctation of aorta. Association of chromosomal abnormalities is still low, and this still needs to be validated. Differentials, truncus arteriosus, interrupted aortic arch. Prognosis if untreated, mortality rate reaches up to 40 to 50% in first year of life and depends on associated anomalies and presence of pulmonary vascular disease. So this was a case of AP window, which was diagnosed at 21 weeks. Thank you so much. I would like to thank my guru, Dr. Adi Narayan Makam, who's always there with us, and my another guru, Dr. Varun Thakur sir from Pune, Dr. Purvi Agarwal from Raipur. Thank you so much. Thank you, Alok sir, and thank you, Ashok sir.
Thanks, Kulbhushan. Excellent case, and you actually made it sound very easy to diagnose, but everybody here will tell you that it is so difficult to diagnose an isolated AP window, and this is not something easy. So excellent case. Thank you so much. We will discuss all this later on with the questions. Thank you.
Thanks.
So next we have Dr. Zulfikar Ronak, and if we think Kulbhushan is passionate about imaging, Zulfikar is mad about imaging. So you just need to see his images to believe that something like this can be done. So over to you, Zulfikar. We are waiting eagerly to see your cases. Thank you.
Thank you so much, Alok sir, for kind words. First of all, words of gratitude towards Dr. Ashok Khurana sir, Dr. Mohit Shah sir, Dr. Bimal Sahani sir, Dr. Alok sir, for giving all of us such a huge platform to present our cases. Thank you so much, sir. So, coming to my cases, I'll be presenting TGA, transposition of great arteries. That will be both the type D and L or congenitally corrected TGA. So coming to the first case, which is Dexter or DTGA. Why it is called as Dexter? After seeing the images, we'll come to know. Dexter means right, or dextro means right. So whenever we listen the word TGA, in our mind, we see for the discordancy. And in DTGA, we are going to see for two discordancy, two vessel discordant, we'll see in the images. So this is 4-chamber view, 2D image, showing a normal configuration of heart, normal left-sided heart. I already fixed the situs. Whenever we do the cardiac imaging, the first very necessary thing is to make the situs. by making the situs, we have done 10% of cardiac imaging, and that is very necessary. I have done the sided thing, and heart is on the left side, normal axis. All morphological chambers appear on their dedicated sides with the normal morphology. As we can see, right ventricle is showing moderator band and tricuspid valve is attached directly to the valve. Left atrium is showing pulmonary veins and aorta is just behind the heart. Retrocardiac space is normal. So 4-chamber heart is completely normal. Here I would like to add a point. Those who are doing cardiac imaging and doing only 4-chamber view are 100% going to miss DTGA type of anomaly, because in DTGA 4-chamber view appears completely normal. So this is request, you have to go beyond the 4-chamber. Coming to the next image, 3-vessel tracheal view. Here, as we can see, a single large vessel is seen along with the SVC. This vessel can be straight or this can be curved. And this vessel is on the left side of the SVC. Presence of single large vessel is not specific for DTGA. This can also be seen in DORV or pulmonary atresia with VSD. So we have to go ahead. Again, with the color Doppler, what we are seeing is single large vessel along with the SVC. Now this image is short axis view for the great vessels. Here, that this section is just below the 3-vessel tracheal view. Here, what we are able to see is a single vessel which is sitting anterior and to the right side of the vessel, which is branching. A branching vessel, we take it as a pulmonary artery. So this vessel is definitely aorta. And this is sitting anterior and to the right. And that's why here it comes dextro. The nomenclature of the TGA depends upon the location of aorta. When aorta is right to pulmonary artery, we call it DTGA. When aorta is on the left side to the pulmonary artery, we called it as a LTGA, or nowadays we used to call it congenitally corrected TGA. We will see in the images. So moving to the next image, this is the most important image to document the discordancy of the vessels, great vessels. Here we can see the left ventricle and a vessel arising and bifurcating into 2 vessels. And definitely it will be a pulmonary artery, which is giving right pulmonary and left pulmonary artery. And the right ventricle is giving aorta. So here we conclude that there is a discordancy of the ventriculoatrial system. And this is the typical image we have to document for. Now to show the parallel course of the vessel, this is the oblique view of the heart, where as you can see the ribs, oblique ribs, arrows marker. So left ventricle is a pulmonary artery is arising from the left ventricle and aorta is arising from the right ventricle, and aorta is sitting anterior to the pulmonary artery. There is a left pulmonary artery branch can also be seen in this image. So parallel course of vessel. Color image showing the same thing, parallel course of vessel. One more thing, both the vessels should be well delineated with the septum. There should be septum in between. Here, aorta is anterior, pulmonary is posterior to the aorta, and left pulmonary artery branch can be seen. Again, the sagittal section of the arch here to document that aorta is anterior and it is showing the arch giving the 3-vessel and pulmonary artery is posterior. Here is the isthmus and right ventricle is giving rise to the aorta. Some additional views, bicaval view appears normal, arch of aorta appears normal. Thymus, we have to look for thymus in every cardiac cases, every cardiac positive cases, because hypoplastic thymus is directly or indirectly related to the 22q11 gene, which that gene is actually responsible for embryologic development of the heart. And thus, to image for the cardiac abnormality, we have to see the thymus. And in our case, thymus appears normal. Now coming to the cine clip, as we can see with the stomach on the left side, heart is pointing on the left side, moderator band, right ventricle, PA arising from the left ventricle, aorta is arising from the right side, right ventricle, morphologic right ventricle. Both the vessels are parallel. Color flow, cine, again showing the same thing. Branching vessel arising from the left ventricle, pulmonary artery. Aorta is arising from the right ventricle and the parallel course of the arteries. 3D imaging helps to demonstrate the morphology of the atrium or the heart structure very well, and it adds on the confidence to report the case. So here we can see right ventricle showing moderator band. Moderator band, and both the vessels are parallel to each other. Left ventricle, pulmonary artery arising from there. So that is very clearly seen in this. Again, right ventricle, aorta is arising from right ventricle, left ventricle, PA, and branching vessel is seen. Parallel course, we can demonstrate very well on 3D. TUI, tomographic imaging, is very helpful in correlating the structures. Now coming to the embryology, till we have documented a case of DTGA, Dexter type of transposition of great arteries. Embryology, I will not go very much deep into. Cardiac embryology is basically into 3 stages. It is primitive heart tube formation. Second one is the looping of that tube. And third one is the septation of atria, ventricles, and outflow tracts. The problem is with the looping of the tube. And the looping of the tube occurs at the 23rd day of the post-conception. So this abnormality tends to arise very early in the gestation. Associated cardiac findings with the DTGA is the very commonest thing is VSD, and that can be seen up to 40% of cases. Perimembranous VSD we can pick along with the TTGA. Pulmonary stenosis we can see into the 20% cases. Extra cardiac findings are very rare with the DTGA. Prognosis and outcome. This is very necessary thing to understand, because DTGA is ductal dependent. Why ductal dependent? Because the oxygenated blood is going into wrong direction, and as per so, deoxygenated blood is going into systemic circulation. So basically, foramen oval and ductus arteriosus helps in mixing of blood, and thus DTGA is well tolerated in utero. But there is one more problem. Pulmonary artery is taking oxygenated blood to the lungs and continuously bombarding with the oxygenated blood. That's why foramen oval and the ductus arteriosus premature closure is always seen in such cases. And for that, we have to rescan, serial scan such cases at the 3rd trimester to look for the foramen oval patency and the arteriosus patency. If there is suspicions or if there is closure or narrowing is seen, then these fetuses has to undergo emergency procedure or to be on the prostaglandin part for the survival. So delivery at tertiary center is very helpful for the good survival. Diagnosis of DTGA early in the pregnancy is very necessary for the counseling of the parents, for the planning of the pregnancy delivery at the tertiary center. Differential diagnosis. There are 2 differentials, DORV and corrected TGA. Corrected TGA we are going to see soon, and DORV and DORV, both the great vessels tend to arise from right ventricle, and left ventricle is devoid of a great artery. But in TGA cases, both the ventricle gives a great artery. So this is the differentiating feature. Now, systemic approach for the DTGA. First of all, branching of LVOT in axial plane. LVOT, don't confuse it with LVOT. LVOT is left ventricular outflow tract. The left ventricle is giving pulmonary artery. And thus, if we see pulmonary artery by the bifurcation, or we can confirm it is a discordance. And once the discordance is confirmed, DTGA is confirmed, DTGA confirmed, three vessel view. If single great vessel is seen or two vessel can be seen side by side, assess for the VSD. If there is VSD, then it is a complex type. If there is no VSD, it is a simple DTGA. After which, check for patency of foramen oval and DA in third trimester for planning of the delivery. How not to miss DTGA? Only 4-chamber view is not at all sufficient. 3-vessel tracheal view is very important to include in protocol along with outflow tracts with color. So we have to go beyond 4-chamber to detect DTGA. Takeaway right now, I'll not go with these points. And this one thing I'd like to mention, prognosis of DTGA is excellent when detected prenatally and child is born at tertiary center. Now coming to the second case, LEVO, previously known as LEVO, or now known as congenitally corrected transposition of great artery, CCTG. So here what we will be seeing is 4 discordancy. 1, right atrium, left ventricle discordancy, left atrium, right ventricular discordancy, and 2 great vessel discordancy. So coming to the 4-chamber view, here now see very carefully, heart is on the left side, but left side apex is formed by the right ventricle. Why right ventricle? I'm calling it as a right ventricle. 2 things. One is the moderator band is well visualized, and second thing, tricuspid valve is well attached to the wall. So it is a morphological right ventricle which is located on the left side. Smooth marginated large ventricle is located on the right side, that is morphologic left ventricle. Left atrium with the pulmonary veins seen on the left side at its dedicated site, and right atrium with the smooth margin is seen on the right side. Basically, valves are, as we know, valves are committed with the ventricle. Wherever ventricle goes, valves goes along with. So right ventricle is now seen on the left side and tricuspid wall is seen along with. So there is discordancy between the atrium and the ventricle, as we can very much see. Now coming to the next image, that is 3-vessel tracheal view. Now this is the image. I'll like to mention that single large vessel is seen along with the SVC, but see the distance between the SVC and the single large vessel. And here I have kept the small image which is of DTGA. See the distance between the large vessel and SVCs, there is no distance. They are in the proximity, but here the distance increases. This is the best point to differentiate between the DTGA and CTGA. Distance will be increased. And why this distance is increased? Because aorta is arising from right ventricle and now right ventricle is on the left side. Because of this distance has been increased. On the color, we are seeing the same thing here. DTGA, no distance. CTGA, there is a distance between the SVC. Now, coming to the 5-chamber view, here we can very well document left ventricle, pulmonary artery is arising from left ventricle and giving branches into LPA and RPA. Here, moderator band seen in the right ventricle giving aorta. So aorta is arising from right ventricle, pulmonary artery is arising from left ventricle. Again, discordancy. Same thing with the color image. We can see right ventricle, aorta, left ventricle, pulmonary artery, both the branches. Parallel course of great vessels are seen, 2D image, color image. Aorta is sitting anterior to the pulmonary artery. Now, in this case, there was a VSD, here 2D image showing defect, and the color is flowing through towards both the ventricle in between. Again, color showing the flow in between the ventricle, VSD is very well seen. Coming to the cine lobe, stomach on the left side, heart is also pointing towards the left side. And as we can see, great vessels are arising from the discordant ventricles. We can very well see in this cine lobe. Pulmonary artery arising from left ventricle, morphologic left ventricle. Aorta arising from morphologic right ventricle, which is situated on the left side. Now we'll see the VSD. 3D rendering showing the same thing. Moderator band, right ventricle, aorta is arising from right ventricle. Sorry, might be my system has hanged. Yeah. Left ventricle, pulmonary artery is arising from left ventricle and giving branches. VSD is seen on 3D rendering. Color flow going through the defect. Parallel course of great vessels. Now, associated cardiac finding in CTGA. Many of the cardiac anomalies are associated with the CTGA, particularly VSD. We can see the perimembranous VSD up to the 70% of the cases, pulmonary stenosis in 40% of the cases, and tricuspid valve anomalies up to 33% cases. So CTGA is more associated with the cardiac abnormalities. Extracardiac findings are very rare in the CTGA. Prognosis and outcome. CTGA prognosis is good. Tricuspid dysplasia and regurgitation should be counseled in the postnatal life. Heart blocks are very common with such kind of hearts. So if you see such kind of abnormality, counseling have to be done regarding the postnatal life after 10 years of age or so. Delivery at tertiary center is advocated. Differential diagnosis, again, double outlet, right ventricle, DORV and DTGA. We have already gone through DTGA and DORV. Systemic approach, again, abnormal four-chamber view. Here, your four-chamber view can give you a clue of some abnormality. Identify anatomical LA and RA. Now, morphologic LA connected to morphologic RV, and the same on the opposite side. CTGA suspected. Now we have to document from where pulmonary artery and the aorta are arising. Pulmonary artery recognized by branching, and it is arising from morphologic left ventricle. So by this, we can reach up to the diagnosis of CTGA. How not to miss CTGA? Be careful in your four-chamber view. 3-vessel tracheal view is very important to include in protocol, again, along with the outflow tracks and the color to be checked. Now, takeaway in this, there are a lot of points, but I'll emphasize on survival rate, exceeded 80% in prenatally diagnosed CTGA with pregnancy was continued. Now I'll compare the DTGA and CTGA in simple points. If we talk about ventricles, so in DTGA, ventricles are at the normal positions. Rather in CTGA, they are inverted. Right is on left and left is on right. Right ventricle, that's what we are talking about. Right ventricle in DTGA is on right side, but in CTGA, it will be on left side, as we will see for the left one. Tricuspid valve is on the right side in DTJ because the right ventricle is on the right side only. But in CTJ, right ventricle moves to the left side. That's why tricuspid valve we see on the left side. Mitral, same thing for the mitral valve. Ventricular septal defects are more common with the CTGA as compared to the DTGA. Pulmonary artery. Now, pulmonary artery arises from the left-sided ventricle in DTGA as in opposite with the CTGA. Aorta is anterior and right side in dextro, whereas it is anterior and on left side in the congenitally corrected TGA. This point has to be keep in mind. Associated extra cardiac findings are VSD and pulmonary stenosis, and here a lot of cardiac findings are there. Thank you so much.
Thank you, Zulfikar, for excellent cases, wonderful images as usual, and the way you employ 3D stick, to demonstrate your findings. It's absolutely fantastic. Yeah. So now I would like to invite Khurana sir to give his comments, and then we will have some break, and then we will go on to the questions which are there in the chat box. And if people are interested, then we can answer a few questions more. You just need to put in the chat box. Khurana sir, are you there?
Yes, thank you very much. It's indeed very, very heartening to see the Youth Brigade doing so well. We know that this was specially organized to encourage young talent within the Society of Fetal Medicine, something we have always believed in. The original Youth Day, as we all know, was to celebrate the birthday of Swami Vivekananda, and he is the first person to have emphasized really that progressive nations have to depend on youthful people, and we have a perfect example here today with us. And my congratulations for Colonel Rima Bhatt for coming up with these idea in the first place. And thank you, Alok, for taking this forward. We've seen 4 excellent presentations. And what was really remarkable was that young people are using high-end technology along with their high-end thinking to make sure that we serve humanity as best as possible. Thank you, all of you, for being such brilliant speakers. And I'm sure we're going to enjoy the question answer session. I think what we will also do from now on is to make this not just an annual event, but try and organize a 1 month each chapter so that they can put their young people together, put someone like Alok in charge, and make sure that Mohit Shah carries on this grand tradition. So here we are, and over to the question answer session.
I think first we would, have a presentation, video presentation from.
Sure enough.
Yes.
Yeah.
And then we'll. Yeah, thank you so much, everyone. Wonderful presentations from all the presenters, and there are accolades flowing in from our delegates. And at one time there were 200 plus delegates who had joined for listening to all of you. And there are some very thought-provoking questions if the presenters would like to take them. So the first question is by Dr. Avinash Gomkale. He always puts forward very thought-provoking questions. So the first question is, why is there is axis deviation in conotruncal defects? So can anyone of the presenters can take this? So I think because we will be running short of time, so let me take this question. We know that the cardiac development, as Zulfikar showed us, that it occurs in 3 stages. First is the formation of the cardiac tube. The second is the looping of the cardiac tube. And now this looping is very, very important. And because this, first of all, tells us which is the right side and the left side of the heart. And it brings the right ventricle, the future right ventricle anteriorly and the left ventricle posteriorly. And then the heart also is rotating so that the apex is now pointing towards the left side. Now it has to stop at some point. Okay, but because if it moves too much, then we see left axis deviation. And once this has happened, the looping has happened, then we will have the process of the septation of the heart. So it happens 2 ways. So one is from inferior to superior, that is the formation of the ventricular septum. And then we have the division of the truncus arteriosus by a spiral septum. And this spiral septum and the interventricular septum, they have to match. They have to join together. So if the heart is looped too much, towards the left side, or if it is, in mesocardia, then these septations, they will not match. And then we will have more occurrence of these defects, the conotruncal defects, as we call it. So whenever we have axis deviation of any kind, we have to make sure that all these congenital heart defects, particularly conotruncal defects, they are, we have to rule them out. So this is, I hope I could answer sufficiently. The second question is, what is the color setting to differentiate double aortic arch and right aortic arch? So Dr. Gurdeep, can you take this, please?
Basically we use the settings of pulmonary veins or the first trimester settings, which are basically adjusted to detect lower PSV. So the scale can be reduced if you have got the machine scale of PSV can be reduced, and it will be able to detect the pulmonary arteries also, pulmonary veins also, and the aortic arch, the coronal diverticulum also.
So basically, the thing is that because we are looking at very small vessels, we need to reduce the PRF, we need to reduce the wall filter. And
use power Doppler also.
Yes, so we can also use the HD flow and power Doppler to detect the flows in these small vessels. So this is how we can detect. The next question is for Dr. Mansi. It's by Dr. Manisha. She's asking, when can we diagnose tetralogy of Fallot? Is it possible to detect at 18 to 19 weeks? Because at many times when we see a case, the anomaly scan is normal, but in the 3rd trimester, we see absolutely, wonderful signs of tetralogy of Fallot in the 3rd trimester. So how is it missed? When can we earliest diagnose tetralogy of Fallot? Any tips? How can we diagnose this?
Sir, we can diagnose as early as first trimester if we use a transvaginal approach, because in that the resolution is high, so we are able to see the malaligned VSD or the overriding of the aorta. However, the tetralogy of Fallot is a progressive disease. So earlier we might just be able to see a malaligned VSD, and that can be easily missed. But the pulmonic stenosis component can develop later on. So that's why a few mild cases of TOF are diagnosed in 3rd trimester. Only moderate to severe cases of TOF can be diagnosed early, or cases with pulmonary atresia obviously can be diagnosed early. However, absent pulmonary valve syndrome can be diagnosed best at the time of around 20 to 22 weeks. That is at the level of level 2 scan, because the dilatation of the pulmonary artery and everything develops later on.
Purana sir wants to make a comment.
Yes, exactly what Mansi said, that really the more we go beyond 20 weeks and closer to 22, we will make many more cardiac diagnoses. And this is the reason why we must share the way we work with our obstetricians who work with us. So whereas the obstetricians who are in fetal medicine are very aware of this, the practicing obstetrician is still pretty much unaware of the fact that the legal limit for MTPs has shifted to 24 weeks, and that the visualization of fetal anatomy is far better at 22 weeks compared to 18 to 19 weeks. 30% more fetal anatomy is seen at the 22-week window, And therefore, the anomaly scan must shift to the 20 to 22 weeks window. And we must educate our patients about this. We must educate our peers about this. And the practicing obstetrician must be fully aware of this. So the more we take this forward, the better it is, so that at least we know from the beginning, for those patients who want a choice on things like untreatable heart disease, they have the right choice at the right time.
Excellent. See, we must consider that TOF is a kind of an evolving abnormality. So some cases they are bound to be missed, but if we focus on left axis deviation, and if we take 5-chamber view, LVOT view in every case, then we should be able to pick up many more the VSDs, the overriding vessels. And I focus in particular at the caliber of the pulmonary artery. So if I find there's a subtle difference, it has to be little bigger than the aorta. But if I find there's a subtle difference, if it is appearing smaller, then I make a concentrated effort to rule out that it's not TOF. It's TOF. All right. So the next question is color settings we have done. How to diagnose overriding pulmonary artery? Kulbhushan, can you take this, please? How can we diagnose overriding pulmonary artery?
So as Mansi ma'am has very well explained in her thing, you have to look where is pulmonary artery arising more towards. It's going towards the right, right. Overriding is happening how much towards the left side, and we have to see the origin.
Yeah, so basically we start with a 4-chamber view. We try to see if there is any defect. But in many cases, the perimembranous VSD will not be able to see on a 4-chamber view. So we have to do a 5-chamber view, or the LVOT view, as we call it. And then we can see the defect and the overriding vessel. Now, we do not know in the beginning which vessel is it. Is it a pulmonary artery or is it the aorta? So we need to trace that vessel and see if it is branching or not branching. So once we find that the vessel is branching, we say that it's a pulmonary artery. And if it is a non-branching vessel, which is in fact more common, then we say that it's the aorta which is overriding the ventricular septal defect. Thanks, Kulbhushan. The next question is by Dr. Gitanjali Behel, and she wants to ask, can we differentiate absent pulmonary valve from a dysplastic pulmonary valve on an antenatal scan? Difficult question. Mansi, would you like to comment on it?
Sir, absent from a dysplastic.
So,
Sir, when I read absent pulmonary valve syndrome, it was written absent/dysplastic pulmonary valve.
yes, so we know that the valve is not absent in absent pulmonary valve syndrome. It is dysplastic, and because it is dysplastic, it is not able to hold off any flow,
It's not opening well, it's not
yes,
closing
it
well.
is not opening well, it is not closing well. However, we have recently seen a few cases, because in absent pulmonary valve syndrome, there are a few types, and one of the types is in which there is no VSD. There is no overriding vessel. Okay, so they are also have been classified as absent pulmonary valve syndrome simply because the valve is dysplastic and it is severely regurgitating. So this is my opinion, my theory, that it is probably just a stenotic valve which became so dysplastic that it is not able to hold off any pulmonary artery flow, and it regurgitates so badly. So, but ultimately the pathology, the pathophysiology is going to remain the same. If the valve is leaking too much, that is going to lead to hydrops. Okay, so the next question is criteria for early closure of foramen ovale and ductus in DTGA. So Zulfikar, that was your case. Can
Yes,
we
sir.
diagnose?
Sir, if we talk about foramen oval, then if we take the foramen oval in the 3rd trimester, if it is too badly small, or if you say in the measurement term, it should be greater than 2 mm at least. If it is less than 2 mm, then it is tend to be early closure of the foramen oval in case. And ductus arteriosus, if it is too badly constricted, the peak systolic velocity through the ductus will definitely shoot over, and then we have to measure the peak systolic velocity. Sir, if you like to add.
So the foramen oval, you can, visually have an impression that you have the valve, the flap, which is bulging more.
Yes, sir.
There's an aneurysmal dilatation. And when you put on the color Doppler, you can see a jet of flow across
Yes,
the restricted valve.
Well,
And if you measure the flow velocity, we will see the restricted flow of high velocity, peak systolic flow velocities.
right.
And this often leads to the increase in the right heart pressures. So you will have a dilated RV, which will be, poorly contracting. You will have tricuspid regurgitation. So all these signs are there. And one more sign we can see, we can place the pulse wave Doppler in the pulmonary veins.
Yes, sir.
Okay, so that also.
To look for the flow.
Yes. So that will also show us restricted flows in the pulmonary. All right, so that is that. So I am not sure about any measurement criteria per se of foramen oval.
Yes, sir.
Yeah, so but visually you can have an assessment of the foramen oval. So it's very important in cases of DTG.
DTG.
It's more important to look for it.
Yes.
Yes,
In
sir.
the sense, we counsel very nicely saying, okay, DTGA, very good prognosis, outcomes are very good, but you need to follow up and look for this because DTGA is a ductal dependent lesion. So we need, and especially if there is no VSD, then it's very, very important because these babies would immediately require some intervention and hence definitely need to be delivered in a tertiary center if the foramen oval is getting restricted.
Also, in that tertiary center, we must make sure that there is help available for an urgent balloon atrial septostomy, because that is really the procedure that the cardiac interventional person should be familiar with, not just enough that the person should know the dose of prostaglandin.
That is true. And we know that if we have an antenatal diagnosis and we have managed to, send this patient to a good center, the prognosis is so good in cases of DTG after surgery. It's quite good. The next question is the first case. Kindly explain the first case in short. So Dr. Ariba Sheikh, she was not able to understand the first case. Gurdeep, that was your first case?
Yeah, I think because we're going to put this onto YouTube, they can actually sit in and see this clearly. So the next few questions were pertaining to this. So we are going to put this earlier on our YouTube channel, and perhaps they could sit and watch it at their own pace and we could cover it then.
Correct. So that was the case of right aortic arch with left-sided ductus. So the aorta, it came not on the left side of the trachea, but it came on the right side of the trachea and it joined the ductus, which was, on the left side. So there was a retrotracheal communication between the two, and that communication is called as comerus diverticulum. Then the next question is, please show AP window case again. So again, we will put this on the YouTube channel and then you can have another look at the case. What is the minimum size of AP window? Kulbhushan, you had discussed something about the size of the AP window.
So there's no definitive size given or any publication as yet. They have given their size, what was the size given to in their case. And in my case also, the size was around 8 to 9 mm. So basically the size is, there's no definitive criteria for size right now. Only we have to just rule out where are we looking at the defect for differentials. That's also.
So basically what happens is that it is not easy to diagnose.
Yes.
And we tend to overdiagnose these cases.
Yes.
Okay, so that is why we need to at least pick up those big defects, which are 8 millimeters or nearabouts. And if there are small defects, they are extremely hard to pick up.
Yes, sir.
Okay, so the next question is, what are the causes of increased distance between the aorta and SVC with no PLSVC? So Zulfikar, you presented in your case in the CCTGA,
Yes, sir.
we know that the distance between the aorta and the SVC it gets increased. Yes.
That is because of the
Yes.
as the aorta is arising from the right ventricle, and right ventricle is sitting on the left side. So aorta is much more pushed to the left side. And
Correct.
that's why the distance between the SVC and the aorta has increased as
And
compared to in DTGA.
yes, in DTJ they appear very close together.
Yes, sir, very close to in approximation.
Correct. So I think we are done. Any more questions? So
There's a question on measurements of the branch pulmonary artery. Should we do them routinely?
Routinely.
Dr. Kanchan Mukherjee wants to know, do we need to measure the branch pulmonary arteries routinely?
So generally, when we are saying something like a routine examination, we are actually not measuring anything except for maybe heart rate. So we have to make a visual impression that something is off, something is wrong. And then once your screening the screening examination is failed, then we have to do a full detailed examination. And those cases, probably, yes, it will make sense that we can measure the branch pulmonary arteries also. But I hardly measure them routinely.
Yes, we would agree there that most of the assessment really is a subjective assessment. The more you see, the more you learn to recognize them. And when you spot an abnormality, we will measure it to see progression. Yeah.
And Dr. Prachi Singhal, she was of the opinion that APVS can be diagnosed in the first trimester. Yes, a few cases can be diagnosed in the first trimester. I saw a wonderful case by Dr. Bimal Sani just a few days back, and very nice case in the first trimester. But by and large, that dysplasia happens gradually, and we start seeing most of the cases of APVS in the late second and third trimester. So first trimester cases are still our exception.
Basically, the dilatation of the pulmonary artery does not happen much in the
Yes.
first trimester. We do not appreciate them, actually.
That is true.
One last question which has just come in from Nitin Yadav, and he wants to know from Dr. Zulfi, I presume, why do we see only a single vessel in the three-vessel trachea view in TGA?
Basically, this is the yes, sir. Sir, are you asking?
No, you go ahead.
Okay. Basically, due to the switching of the vessel, or what we call is discordancy, pulmonary artery in normal fetuses, it runs side by side, aorta and pulmonary artery. But in the TGA case, pulmonary artery is very much inferior to the aorta, and that's why in three vessel view, only a single vessel called aorta is seen.
You need to go oblique to find it.
To find it,
Yeah,
yes,
because
sir.
they're parallel.
It will come under the aorta.
Yeah, it's behind. That's why we see.
Yes,
Yeah.
sir.
Yes. I think it was beautifully emphasized by Dr. Zulfikar that really speaking, the parallel vessels are not seen in any standard view that we normally use for cardiac evaluation. And we suspect it on the basis of these other findings and confirm the parallelism by using that oblique view where he showed that beautiful cross-section through the ribs. So that it becomes an important view for confirmation. And the story, of course, begins when we start spotting the single vessel in the three vessel T view.
Yes.
Excellent.
Yes. In fact, if we see a normal four chamber view and if we see single vessel in the three vessel trachea view, that is really alarming. We need to look for all the differential diagnoses, the common arterial trunk, the TGA, CCTGA, HLHS, and all those cases.
If you find that the single vessel appears of a normal size, then it is more likely to be a parallel vessel. And if you find that that is dilated, then it could be a cat, or it could be either one of the vessel with other vessel being atretic, some compensatory this thing. So that also gives you a little bit of clue. So 3VT view, honestly speaking, I think at the end of the day, we can say that 3VT view is the most important view to take actually, because that is the one which gives you a suspicion to look for things.
That view is severe.
Always.
That is true. So I think we do not have any more questions.
That is right. Yes.
Okay, so thank you, everyone. Thank you, everyone. First of all, the delegates who have attended this webinar. And thanks to all the presenters who presented their cases wonderfully, and all the seniors who are there with us, Khurana sir, Bimal sir, Mohit sir. I think he was busy today, but he was there at the beginning of the webinar. And thanks, everybody. Thanks, Vishal, and Conference International for the back-end support. So let's call it a day.
Thank you very much and congratulations.
Thank you.
Wonderful.